Now we have also the cross trial. So this was also done parallelly. This was published in New England Journal, and this was surgery alone versus preoperative chemoradiation. So the previous trials were only chemotherapy, and this was a chemoradiation before surgery versus only surgery. So this was again a seminal trial. This established preoperative chemoradiation as the standard of care at that time. And this was the chemoradiation regimen for the surgical colleagues. What you need to know is that this is a very easy, compared to the ECF and the FLOT, this is much easier to administer because the chemotherapy regimen is very simple and straightforward. It is a weekly once regimen. It hardly takes 2 to 3 hours to administer it. And it is usually, the chemo part is well tolerated. The radiation dose is not very high. It's only 41.4 gray in 23 fractions. So it is completed in 5 weeks. And after this chemoradiation regimen, patients were then taken up for surgery, and the control arm was only surgery. But what you should know is that this trial, like all trials, they have very strict inclusion-exclusion criteria. The criteria were very strict. So, patients could not lose more than 10% of body weight. The maximum craniocaudal length allowed was 8 centimeters, so on and so forth. And 3/4 of the patients were adenocarcinomas. So this trial also showed that chemoradiation was significantly better when added to surgery in terms of overall survival. The median survival improved from 24 months to 49 months. The R0 resection rates 69% in surgery alone arm, a little inferior compared to today's standards, but significantly improved by application of pre-op chemo-RT. What was very clear is that the squamous subgroup benefits the most. So if you see the difference in the outcomes for the squamous cell histology is much more significant than the benefit for the adenocarcinoma histology. So the median survival jumped up from 21 months to 86 months for the squamous subgroup. Adeno subgroup, the benefit was there, but a little bit more modest. So the question remained for many years. When we had both the FLOT on one hand, we had the cross on one hand, what is better? Especially for adenocarcinoma histology, we did not know what to offer and what is better. That debate raged for many years, and there was always a debate, especially in MDT meetings, that what is best. But now we have the ESOPEC trial, which took a long time to accrue, and finally we have the results now. This took only esophageal adenocarcinomas, T2 node positive cases, and this was a superiority trial. It was designed to show the superiority of FLOT over the cross protocol and overall survival, which is a very important primary endpoint. That was the endpoint of the trial. And here, FLOT significantly did better than cross. There's no doubt about it. Even the pathological complete response rates, little surprising, little bit inferior with cross on 10%, but it was a little better with FLOT. And the median survival was significantly better. You can see the 5 years survival jumping from 38% to 50%, and the median OS jumping from 37 months to 66 months. So for esophageal adenocarcinomas, now this trial has settled the debate that perioperative FLOT definitely outperforms cross, and this is because of better systemic control of disease. As one of our surgical colleagues was telling that the systemic control is inferior with FLOT, with cross, and this is a recurrence patterns which clearly shows you that with FLOT, the distant metastasis rates are much lower compared to cross. In cross, almost roughly 30-35% patients will have distant metastasis, and with FLOT, because of the reduction in the distant metastasis, the overall outcomes are better. So finally, looking at the guidelines, what they recommend, the standard of care for today, for squamous cell carcinomas, T2 or node positive, even now the cross protocol is preferred because of the excellent outcomes seen in the cross regimen, and definitive chemo-RT for those patients who are not surgical candidates. But for adenocarcinomas, with the ESOPEC data now in place, T2 node positive cancers, the preferred treatment is perioperative chemotherapy with the FLOT regimen as of today. And those patients who are not candidates for FLOT for whatever reason, they go for chemoradiation. The rare subgroup of patients who have mismatch repair deficiency, that is something which I did not cover because it would be outside the scope of this talk. But those patients who have MMR deficiency, they can go for neoadjuvant or perioperative immunotherapy. Thank you so much.